Hello, my name is Enrique Alvarez, and I'm one of the neurologists at the University of Colorado and part of the Rocky Mountain MS Center. Thank you very much for listening in today. Very excited about having another educational day. Today, I'm going to be talking a little bit about COVID and especially as it affects our MS patients. All right, just as a reminder, this is being recorded on April 5th, so a few days before the presentation, so hopefully not much is changing during this time. We'll talk a little bit about the numbers. We'll talk about some of the risk factors. Some of these sections may be a little bit similar to sections that were presented in the past. And then I'll provide some update on vaccinations as they're available now. So just to go over the numbers in the United States, if we look at the data from the New York Times, we can see that there's a small increase in number of cases over the last week. This is a fairly small bump so far, but we have to remember that a lot of times some of these bumps are more regional than across the United States. So we can see that Michigan has very high numbers currently. And even if we try and concentrate on certain states, that in certain areas we can see much higher numbers. For example, if we look in Colorado, we can see that around Grand Junction and Durango, that the numbers are much higher than other parts of the state. And we're starting to kind of see about other small pockets of cases throughout the United States. As we look at globally, this newest bump, or sometimes what they're starting to call now the fourth wave, is much more pronounced. There's cases globally going up by about 22% over the past week. And these are being hit very hard in certain countries, such as France. France is having a huge issue right now with their ICUs being almost completely full. Versus in the United States and Canada, again, we can see that the numbers aren't too bad. Brazil also being pretty high up on the list. And so one of the things that we're starting to see is that, and had been predicting throughout this period of time, was that some of these variant strains were going to take some time to take effect, take over, and that what we're starting to see is that those variants are starting to kind of take over and kind of spread much more quickly. It's a little bit of a chase to try and see about vaccination rates, and I think that that's one of those things that has helped us in the United States. So these are kind of the latest numbers. We have to kind of keep track as well in deaths in the United States. Well, in pretty much anywhere in the world, we can see that the number of deaths tend to lag number of infections by 2 to 3 weeks. That the number of deaths in the United States is going down slightly because the number of cases had been going down until recently. That fourth wave in the world had been going up, so the number of deaths is going up in the world. But when we look at number of deaths, we have to look also into how good are we keeping track of deaths. And this is a little bit of an older article, but kind of worth pointing out again that the number of deaths is higher than even what's reported, especially early in the pandemic where testing wasn't very good. And people were not necessarily going to the hospitals for things like heart attacks and strokes, and were dying of other things at home. And so this number of excess deaths and trying to understand that becomes important. The good news that we're coming up in Colorado, for example, is that when we start to look at projections, and IHME, for example, is one of the groups that's doing a lot of these projections, we can see that the number of cases maybe is kind of predicted to kind of go up a little bit over the next few weeks, but really kind of continue on this downward trend. And this does take into account all the variants, for example. We're not expected to have any issues with number of ICU beds or hospital beds really at this point. And so things are starting to kind of look pretty good in our state. And again, in our state across in the United States, looking overall really pretty well. So our numbers are looking okay. I think there's still a little bit of concern about variants and how well our vaccines might work against them. And we'll talk a little bit more about that a little bit later. But because these strains have been associated with more rapid spread of the virus, There's a concern that these numbers could continue to increase. Um, but if things kind of continue as they are, again, everything's looking pretty good. So let's look at some of the risk for MS patients and the idea of trying to identify are MS patients at higher risk and which patients are at higher risks. This should really kind of prioritize who should be vaccinated. And the good news is that as of the last week, now throughout Colorado, everybody's eligible to get vaccinated, which is great news. So as we start to kind of look at some of these have been updated just as far as numbers, but the general concepts are similar to prior presentations in the sense that we can see that um, as we look at by number of cases by age, we could see that the newer waves tend to be a little bit affecting more the younger populations, increasingly so. When we look at mortality, though, we can see that this has really been affecting primarily those who are 70 years old and older, and really those that are much more than 50 and 60s as far as mortality goes again. What are some of the other risk factors beyond age? There's a little bit of an effect by age as well when we can look at some of the similar plots. But the big other one that comes up are comorbidities. And we can see from two different studies that heart disease, things that affect the heart in many different ways, are an issue. And this probably has to be a direct effect that the receptor for the virus is really found in the heart to some extent. And we can see that patients with heart disease have a higher risk than people with other comorbidities, even. Diabetes, chronic pulmonary diseases. There was a lot of mention around asthma, but it appears to be much more a concern for patients with COPD than those with asthma. High blood pressure, a little bit less so, cancer patients, less. And we can see that patients that have no comorbidities really have a much lower risk. When you start to combine several of these, really hardly anybody who died had bad outcomes from COVID had um, any of the comorbidities. So this is great news. But if you start to have more comorbidities, the push really should be on getting you vaccinated, keeping you away from other people, and having to be much more careful, um, generally speaking, about COVID. As we start to look specifically more at MS patients, we can see that there is a lot of factors that maybe affect bad outcomes of severe coronavirus, and this usually is defined as hospitalization or worse. And we could see that as we look at age, being male, having comorbidities, again, mostly cardiac, but also pulmonary diabetes, not much of an effect with smoking. Obesity has a small effect. Being more progressive, having higher disability. These go hand in hand a lot of times. And so in some models, for some papers, you'll see that higher disability is an issue. For some of them, it's that they're progressive versus not progressive, that it's important. We can also see from this study, for example, this was a larger French study that was one of the first studies to be published, that the disease modifying therapies, that the treatments for MS seem to be somewhat protective, especially compared to patients not on treatment. And again, most of the patients not on treatment tended to be older patients with more disability. And you can see that some of these drugs maybe might be more protective than others, for example. This is a little bit controversial even still to this day. We could see that from other studies that when you started looking at different factors and started to kind of come up with multivariate type of analysis where you include everything as opposed to looking at each one individual aspect of it. In the prior study, we saw that disease modifying therapies kind of washed out. They didn't have much of an effect. This is a large Italian group, kind of another big study that got developed afterwards, where we could see that most of these drugs did not have an effect, but we did see an increase with B-cell directed therapies, primarily rituximab and ocrelizumab, of about 2.5-fold increase. We could also see effects for age being male, and again, in this case, not so much disability, but being progressive as part of the factors associated with worse outcomes. Also, if you'd had steroids a month before, and this contrasts out because steroid use is actually being used to treat MS, but if you had steroids a month before COVID, it was associated with a six-fold worse outcomes. There's been a big international effort to combine all of these data sets, and this was presented at ECTRIMS last fall. And here we could see some of these other factors now in a much larger group. This included 1,500 patients. Again, the effect of disability being higher, progressive being higher, although statistically maybe not so much, older age, males, or in this case, females being protective. So when we look at these things individually, kind of following the same patterns that we had seen before. When we look at B cell therapies, we could see that there's a 1.5-fold increased risk of needing to be hospitalized, a 2.5-fold increased risk of needing ICU stay, and about a 3-fold higher increased risk of of requiring a ventilator. However, when we looked at deaths, we didn't see much of an effect. And there's a lot of discussion about whether these medicines are helpful or hurtful. And part of that might have to do with understanding the disease. That is probably different types of different stages of the disease. Early on, when the virus is being very active, you want to have a good immune response. As the disease starts to clear out, there's a stage of the disease where having too much of the immune response is probably not a good thing. And we see that some of these therapies might be helpful at this part of the stage in being able to control that inflammation. So depending on where you're at, and this is helpful, for example, maybe understanding that steroid response. You don't want to have steroids while the virus is maybe being active, but maybe at the end when the immune system is too strong, where steroids might be helpful. Completely different type of data set showing very similar results. In this case, ocrelizumab having a 4-fold increased risk of bad outcomes with COVID, and not much of a difference with the other types of disease-modifying therapies. This shouldn't be too unusual. We can see that with rituximab here in a Swedish group that patients on rituximab compared to other disease-modifying therapies or not on treatment had a higher risk of serious infections. So again, this makes sense knowing what we know about how these medicines work and what they do. When we specifically looked at the use of rituximab, not necessarily for COVID, but for just bad outcomes, and we did this in conjunction with Ilya Keister's group, we could see that there is several factors that really kind of drive this increased risk of infection risk in patients. And primarily the big one is just level of disability. Requiring a wheelchair is being associated with an 8.5-fold increased risk of bad outcomes. A little bit of an increased risk, again, for being male, prior history of immunosuppression, how long you'd been on rituximab, and these kinds of things. But these numbers are much smaller compared to the level shown by disability. We often look at levels of antibodies to look at response of drugs. We worry with B-cell depleting therapies about patients not having enough antibodies. This is a report of 2 patients who had absolutely no antibody levels because they don't make B cells that become plasma cells to make those antibodies. And the good news was that these 2 patients were able to recover from COVID-19. Suggesting that there's other parts of the immune system that become very important, and that this is likely involving T cells and other parts of the immune system. So again, the immune system is a little bit kind of like a military. There's Army, Navy, Air Force, and Marines, and having sort of good strength in one branch of the military can overcome deficits in other parts, and this is important as well for our immune system. So one of the ways to overcome any type of infection is to think about vaccinations. And I think this is being highlighted a lot recently, and we're very excited that pretty much all our MS patients can finally get immunized. We were a little bit scared with one of the phases schedules that kind of came out from the state of Colorado, where MS patients were part of the general population. They did get prioritized, and we're starting to see that a lot of our patients have been vaccinated. So when we talk about vaccines, it's important to talk about the vaccines that have been around for a while. We talk about them as dead vaccines, and usually these were the inactivated. Think about the annual flu vaccines, probably the most common one. These subunit or toxoid vaccines, and probably the most common is the pneumococcal one here. The live attenuated, which we don't really tend to use much anymore. Measles, mumps, and rubella is probably the big one. These are the ones that we tended to be more concerned about because these were the ones that could multiply if your immune system was weakened. And so we tried to avoid these in our MS patients. Here it says the varicella zoster. This is no longer really used. This is the Zostavax vaccine. And the one that's being used now is in the safer group. The Shingrix vaccine is the way we prefer to kind of vaccinate for most of our patients. The new groups are the vector or the RNA DNA vaccines. These are generally considered safe because these cannot replicate. Now, it's important to understand the difference. For example, the vector vaccines, there's some that can be replicating and some not. The replicating vector vaccine that is out and about is the Ebola vaccine. But otherwise, we're starting to kind of really look at sort of the Johnson & Johnson vaccine listed here as really the first sort of viral vector vaccine to come out. Within the DNA and RNA vaccines in the United States, we have the Pfizer and the Moderna vaccines, and we also have this virus-like particles with the human papillomavirus vaccine being kind of the one vaccine in that group. These can be manufactured and developed much more quickly, which was one of the advantage and why we're starting to see these vaccines being available sooner than some of the other vaccine types that have been used for much longer. But here we can see that the RNA vaccines is often sort of encased in a lipid coat to help protect the RNA. RNA is very easy to break down, and you need something to kind of help stabilize it. And so it's important to kind of protect it with some of these lipids or fats associated with it. That's part of the reason why they have to be frozen for long periods for storage purposes. So as we look at vaccines, and the big concern a lot of times has been with patients on B-cell therapies. This was a big study done with ocrelizumab in MS patients. And here we can see that depending on a couple different vaccines, I just picked a couple as examples, that patients on ocrelizumab, and the name of the study is the Veloci study, did not respond maybe quite as well, but we could see that there's still fairly decent response to a lot of these. So depending on which strain, if you were on drug versus not on drug, you could see that probably a good 50% response compared to the control for most of the serotypes, different types of strep pneumoniae. When we start to look at the different flu type vaccines, we can see that you can go from here to here, for example, if you're on drug, and so again, what we can see is that most of the patients, or oftentimes a lot of 50% of the patients after vaccination had antibodies. So on drug versus no drug, 71.4% of patients could develop antibodies, 66.7. Probably the lowest here was 55.6. So these were really reassuring numbers. I'm going to show data that really nobody's probably seen. This was data that we just got last week and just submitted for publication. So we've not even presented this anywhere. This is looking at MS patients responding to the COVID vaccine, looking at antibody responses. What we can see is that when we look at the spike protein antibodies, that after the first vaccine versus the second vaccine, I'm going to concentrate here much more so. We could see that about 10 patients, kind of a pretty good mix between rituximab and ocrelizumab. We did have one ofatumumab patient had low levels of antibodies, with only two kind of considered to be seropositive, versus when we looked at controls that were not on B cell therapies, the lowest control still had higher levels of antibodies than any one of the patients on the B cell therapies. And you can see much higher levels of titers. So pretty good separation here. And this is a little bit more concerning as far as some of these MS patients and sort of recommendations. So we definitely recommend getting vaccinated if you're on B cell therapies. Some of the patients did develop protective antibodies. I think what's also clear is that we're not measuring the full immune response. And that it's important to kind of be able to look at some of those things. And those are the things we're starting to kind of gear up to look at. But it's, again, important to be able to look at this. We did have a patient who had COVID and then was vaccinated, and their antibody levels actually came up to about the mid threes. So this idea of using the vaccine to boost up patients who've already had COVID is, I think, an important idea. We will see that that patients who have COVID, get sick from COVID, their antibody levels actually stay not fairly low. They don't go up much, even if they get fairly sick. And so it seems like, the vaccine just provides better numbers overall. And especially if you've had COVID again, it works as a booster. So there's strategies like that that we can use to look at trying to improve the immune response. This is not uncommon. We can see that even for the flu vaccine, that if you're older, for example, that the responses aren't as good. So 42% of those over age 60 develop good protection against the flu versus 70 to 90% in children and adults. Being older also compromises the B cell, the antibody response to pneumococcal vaccine, to the hepatitis B vaccine. And when you're older, that the antibodies don't last as long. And so we have to look at different ways to vaccinate booster. There's some strategies. We can use higher doses. So the flu vaccine for individuals that are older is 4 times stronger. They can use adjuvants. Adjuvants is the stuff in vaccines that kind of helps kickstart the immune system. And so if we use a stronger adjuvant, that can help build up a better immune response. And that's often done as well, for example, with the herpes zoster vaccine. And part of the reason why the new vaccine is the dead vaccine is because it has a stronger adjuvant associated with it. We can see the strategy of using more vaccine doses as helpful. We could see here the response after vaccination in patients on rituximab. This was actually a study done on type 1 diabetics to a new virus, just a virus that doesn't usually affect us too much. And we can see that after 2 doses, we don't see much of a difference in I should say that after 2 doses of vaccine, that there's a huge difference in antibody responses. But as you start to give a 3rd and a 4th dose of the vaccine, that the levels of antibodies start to kind of match up pretty well. So I think these are strategies that we can learn from and use in our MS patients. And once we have vaccine available, we're going to be trying to do some of this testing. This is also common to be done in hepatitis B, and I'm happy to report that I'm one of these people that responded to having to do double shots of hepatitis B. Just randomly, I did form antibodies after 2 courses of a standard dose, but after doing 1 course of these double doses, I was able to respond. This was looking at alcoholics, but again, this idea of the high dose versus the normal dose, you can see much better response to this vaccine. So there's a lot of vaccines in development. This is getting now to be a bit of an older slide, but as we look at the vaccines that are available, there's 2 RNA vaccines, the Pfizer and the Moderna vaccine, very similar as far as vaccination rates. We can see the vaccine that's not available in the United States. In this case, this is the Oxford vaccine, the J&J vaccine, which recently became available in the United States. Both of these are on the 70%. There's a lot of controversy around the AstraZeneca/Oxford vaccine, and in some countries have stopped using it or they're using it in specific populations. Um, I get a lot of questions around which vaccine should I get, which one has better experience in the United States. If given the option, a lot of times I do recommend the RNA one. I think the numbers are a little bit stronger. I like the idea of having that booster as far as kickstarting the immune system. But honestly, some vaccination is better than none. And so if the one you can get is the J&J vaccine, my recommendation is just to get that. The other question I get is around safety of the vaccines and whether the vaccines were actually tested well or not. And I think one of the important concepts here is to recognize why vaccines got done, the trials got done faster. And you can see here the idea that the vaccines are also are staged in different phases. And when we look at this, that a lot of times you have to finish one phase before going on to the other phase, and it takes some time to kind of develop the next phase. And so in the usual fashion, it may take a long time, 10 plus years to develop these vaccines. And simply what happened was not so much that the studies weren't done, it was just that a lot of time and effort was put into developing these vaccines, and that they were overlapped, so that you would start one phase before doing the other. But all stages were completed. There was a lot of efforts. It would bring in a lot of sites, for example, to recruit patients into these studies, and so that the studies could be done faster because you could get more patients into them, because patients were willing to be part of the study, for example. And so with this, we could see that there was a plan to get the vaccine approved by February of 2021. And actually we got them before that in December. And so we've been using them for some time now, to the point that now we're looking at over 30% of the population in Colorado. These come from the Colorado Department of Public Health website. We're currently in phase 2, which is pretty much everybody can now be available to be vaccinated over the age of 16. I should mention the pediatric studies are still coming online. Sometimes with these sites, I'm not sure that I understand fully the numbers, but there's apparently been more doses administered than they've been distributed. So we'll ignore this number here for a little bit. But we can see that 1.8 million people have been immunized and over 1 million have been fully immunized. We have a population of about 5.8 million in Colorado. So at least 30% have received one dose and over 17% are fully immunized. We could see other websites. So according to the New York Times website, we could see that the number of fully vaccinated Coloradans is actually probably closer to 19%, and over 30% have received the initial dose. If we add these numbers on top of those patients who had COVID and maybe developed antibodies to that, we're starting to kind of look at patients, or starting to look at sort of about 40 to 50% of the population having some protection against the virus. This is an important number, but it's a little bit short of the 70 to 80% of the population that we would like to get before trying to get to herd immunity. We can see that the number of doses is just steadily increasing, and so this is very reassuring. And we can see that in Colorado, we are administering most of the doses, and we've actually been very efficient in giving out the vaccines that we've been given by the state. So what's the process for getting vaccinated at UC Health? We can see that you need to sign up for a My Health account. There's invitations. If you've not gotten an invite, especially at this point, and you're one of our MS patients, please reach out to the hospital, look out for the COVID numbers to be able to reach out to them and ask kind of what was going on or try to get on the list. Schedule both vaccinations. This is important. I think it's very helpful. I've heard of sites where you register for one vaccine and then there's no slots available to get the second dose. And so if you can schedule both of them, then you're set up and that you'll have vaccine available for you. If you get asked about payment, please refuse. These vaccines should be free. Please wear clothes. That makes it easy to get vaccinated. It is a shot. For most vaccines, it hurts a little bit at the arm. There was a lot of talk about sort of quick reactions and anaphylactic reactions. These have, for the most part, not really panned out. We've not seen them, to the point that a lot of this monitoring has actually gone away. If you want to hang out, the opportunity is there to kind of hang out and be monitored, but it's become less of a requirement now. And then you show up for the second appointment, and you repeat it. After the second dose, it's not too uncommon to have flu-like type symptoms. So this is important to kind of remember, to have some Tylenol or ibuprofen, is it's especially for younger people with strong immune systems, it's not uncommon to have some flu-like symptoms, feverish, that kind of stuff. Responds really well to those medicines, and so I think it's important to kind of recognize that that tends to be short-term. Having COVID is not so short-term for most people, and so it's important to kind of get vaccinated. I think there's still a lot of unanswered questions. This is some of the questions. These are some of the questions I get periodically in clinic. Um, what's the response of vaccination MS patients on immunosuppression? Well, there was no patients who were immunosuppressed. The data that I presented is the only data that I'm aware of that's out there. And again, for us, it's not out there. We just literally submitted it as a paper, as a manuscript this past week. We don't expect any interactions with MS drugs. How's the timing? So our general rule of thumb is to try and spread out about 4 weeks the vaccine to your infusions, especially with B-cell therapies. For pretty much any other drug, just continue with your normal schedule. We're sending a lot of mixed messages around infusions, and we get questions about Tysabri patients and trying to time it with them. For those patients, please do not separate and do not delay your treatments. And about 4 weeks, if you have to delay your infusion, that's maybe a little bit better than delaying your vaccine, if that's an option. If you've had COVID already, should I get vaccinated? The answer, I think, is yes. We're not seeing great responses to patients who have kind of natural COVID immunity, especially on B-cell depleting therapies. And so our thought is to try and get you vaccinated. It does look like it's helping to be a little bit of a booster. How long will the vaccines last? This for sure, we don't know. We're collecting some of this data as well, but we're just not far out enough to kind of have good information about this. Which vaccine should I get? Any of them. Again, if you have the choice, maybe one of the mRNAs from Pfizer or Moderna, but I'm not sure that it matters too much. And the important point is just to get them. For people that maybe are a little bit more hesitant about them, the J&J vaccine is nice because it's a single shot. As far as vaccination and pregnancy and breastfeeding, not been looked at, but it's recommended that pregnant women receive the vaccination. So that's been the recommendation. We've had several patients with MS who are pregnant get tested and done really well. And if you're breastfeeding, you could pump and dump maybe that day. But I think the idea is just get vaccinated, and appears to be safe with all the patients that we've seen go through this already. Briefly, just to talk about treatments for COVID. So again, most patients tend to do really well on their own. Convalescent plasma, so antibodies from patients who have recovered from COVID, was kind of some of the first line. Some of these antibodies now are starting to be made kind of artificially. And so these monoclonal antibodies to COVID are now being approved and used in some of our patients. Steroids, we talked a little bit about, that it's probably not good to be on steroids while you're getting infected, but if you're sick in the hospital, getting steroids can improve outcomes and getting you particularly off the ventilator. Remdesivir is being used, and a lot of our patients have received remdesivir and done well with it. There's a lot of other data that we just don't have much data for. Hydroxychloroquine, chloroquine, ivermectin, vitamin C, D. Leeches maybe goes back a little bit of time, but wouldn't be surprised if maybe they make a comeback for this as well. So with this, I think it's important to kind of recognize in conclusion that COVID-19 cases are maybe increasing, that we're maybe kind of at the beginning of a fourth wave, less so in the United States, unless you're in select pockets. Michigan, particularly this week, seems to be kind of a big hotspot. Colorado seems to be kind of fairly stable. With that in mind, vaccinate, social separation, wear your mask, wash your hands, all these things that we've been doing so far are important. But it's important to kind of recognize that from a mental health perspective, that it's important just to get out and about, interact with people, just be safe about it, continue to exercise, continue to eat right, and just be well. For patients on B-cell therapies, timing of the vaccine to the infusions is complicated. We're recommending at least 4 weeks before or after. You'll see guidelines that vary widely. I'm not sure that there's a right answer to this, but I think it's important to recognize that the immune response maybe isn't great. And so just because you get vaccinated doesn't mean that you're protected. It does mean that you probably have some partial protection. And again, we've not seen any deaths on any patient who's been vaccinated. And so having an idea that, still wear your mask, still be careful, but go ahead and start getting together in groups and things like this and return back to normal. And so with this, I appreciate your time again. Thank you very much, and bye-bye.